Welcome. My name is Garry Kauffman. In today's session, we're going to talk about CPT code-based productivity. And we have an expert with us today, Joe Garcia. Joe, would you like to introduce yourself, please?
My name is Joe Garcia. I'm the Market Director for Respiratory Care Services for the Central Valley market in California. I oversee various size acute care facilities.
Well, thanks, Joe. I'm going to start out with the basics because a lot of us, when we went to respiratory therapy school, perhaps even in the day, we heard about charges and billing and reimbursement. But this acronym, CPT, may be new to a lot of our listeners. So maybe let's start at the most basic level. What does CPT stand for? And then what purposes was the system designed to do?
Yep. So it stands for current procedural terminology. And usually there's a series of numbers linked to that, and with also a brief description. It was started back in the mid 1960s by the AMA for physicians. An example would be a surgical procedure being performed, and that physician would know the CPT code, know the description, and then submit it to a payer or an insurance company for the purposes of billing, etc. So that's kind of where it really started from, back by the AMA in that mid 1960s. Somewhere around 1983 or so, in that time frame, CMS, or Centers for Medicaid and Medicare Services, mandated CPT codes for qualifying procedures, and along with the coding company, along with that too as well. So that's really when CPT codes really became gaining a lot of traction as being mandated back in 1983 by CMS.
What you're saying, Joe, is that the CPT codes are arrayed according to procedures, surgical, medical, or whatever, and it's what the physicians use is really the standard when they do a procedure that they use. They assign that to a code, and then that's submitted for reimbursement for the physician services. Is that kind of the crux of it?
Reimbursement also goes to the insurance company as well.
Okay. So it documents the procedure and links that procedure with a particular reimbursement, whether it's Medicare, Medicaid, or a commercial payer. Okay, that's helpful.
Right.
Joe, I like your explanation. I guess the question I have, it sounds to me that the CPT system designed by the AMA, utilized by Medicare, Medicaid, and commercial payers, sounds like that's a good system to link clinical documentation and reimbursement. How was that system then expanded to cover respiratory therapy services?
Sure. As we started off explaining how CPT codes were developed originally back in the mid 60s and then mandated it by CMS in the early 80s, that's when really it started to impact respiratory care services. Whereas before, we were a unit of service billing system, but a lot of those weren't linked to a CPT code. And not until in that early 1980 timeframe, when CMS started to mandate it, is when we started to see the appropriate charge codes being activated for the respiratory care services departments.
Well, that makes sense. And just to give an example from my past, at one point in time, if I did an arterial puncture and it did an arterial analysis, that was reimbursed in the old fee-for-service world in my hospital differently. One for the obtaining the sample and one for analyzing. So is that example where we didn't have codes for some of our services or all of our services, and then they were expanded respiratory therapy?
I think both. I think we had codes that were approved. We were using them correctly. We also were billing. We were billing using a CPT code that allowed us to have unlimited billing and not restricted to quantity billing. where we're at now. So back then it was a little bit different. We had the appropriate charge codes that had the CPT code connected to that, but there weren't any guardrails in place to control the quantities, and some of the documentation requirements also changed from that whole beginning.
Yeah, it's interesting because what it makes me think about is that the code was attached to a procedure, but perhaps those payers were saying that's one step, but how do we manage utilization? And it makes sense to me as they're getting all that data in from different providers, they could see differences in those volumes, kind of almost like what they did with the DRG system, where you get
Correct.
a
Yeah.
set amount for that. You can do all the blood gases and MRIs and CPT that you want, but it doesn't change your reimbursement for that patient, with a few
That's
exceptions.
correct.
Okay. Joe, you said something that gives me another question. Did you say that every service, every procedure that we do has today a CPT code? Or does that not cover all of our services?
So as of today, no. Over time, due to many factors, which I won't go into on this conversation, but we have been limited, or a lot of the CPT codes were limited, or they either reduced quantities per day per encounter when a patient comes into the hospital in their stay. So that really impacted respiratory care services when you had either chart CPT codes that were active now were removed, and also having the limitations on quantities. And another layer to that I may want to comment on is where the patient starts from, maybe from an ER and they stay in ER, then go home, or they're in ER and they go to inpatient. Right now, they have limitations or modifiers that either we have to give charge codes back to the patient status type, and that has also been a new layer where it's called pairings of charge codes, or CPT codes, I'm sorry, that are not matching up. And so we usually have to reconcile those daily. And that's also when you have to give back something and we provided labor to do that service, it does affect productivity in a negative way, basically.
Yeah, I think you and I see on the postings on a weekly basis that someone will say, I spent an hour with the patient. My services were needed. I intubated, I set them up on a mechanical ventilator, and I was there in ED for another 2 hours. However, as you said, when that patient is admitted to the hospital, that gets rolled into the hospital admission. At least that's my understanding. Therefore, that productivity for 2-3 hours that that therapist spent is not captured. Is that a fair way to give an example of one?
That is a fair way example. You're looking at a sort of acuity or time spent with the patient. When you're in the ER, they have what's called a critical care charge. It's kind of a bucket. And so when a patient comes in, one of the most common things we do in an emergency room for under respiratory care services is a arterial blood gas stick. That has a CPT code. It does earn revenue to the department. However, if that patient was to leave the ER, which is great, and then go home, due to that is a critical care charge, and I would have to give that charge back because it already is being charged in basically one bucket or one lump sum to the patient and to the payer. If the patient was to be admitted into the hospital, that critical level status has changed, and that charge would then stand, and we wouldn't have to give that charge back. So that's that third layer I'm talking about. Is it's not just look at the whole hospital itself and all charges that we bill for are going to hit our productivity, but now we are experiencing different levels of specialty areas that could impact the respiratory care services productivity in a negative way.
And I think that's the common lament where RT leaders say we're providing the right care, but because this system either has us give that back, as you described, or when that patient is admitted, we're not capturing all that time. So here's the next question then, Joe. Given that, once the patient is admitted to the hospital, are all the respiratory services that a typical department provides, therapeutic, diagnostic, life support, education, do all of our procedures have a CPT code?
No, based upon my experience nationally, probably easily 30% of our daily life of interventions with patients or interventions / procedures with patients, about 30%-ish we cannot charge for. Example would be maybe a patient assessment. There's no CPT code for that, or transporting a patient from their ICU bed to do a CT scan. It takes time to do that. There's no CPT code for that. So yeah, that is an issue where I alluded to in the beginning, where we have easily at least 30% of our clinical intervention with patients. There is no CPT codes, charge code for those types of interventions.
Yeah, I think that's the fly in the ointment for a lot of RT leaders, where they have difficulty justifying their clinical FTEs based on CPT. And to your point, if only 70% of their RT labor is captured by a CPT code, good for what it is, but how do you justify the other 30%? Joe, you mentioned that as much as 30%, or maybe even more in some departments, of their RT labor is not captured, is not associated with the CPT code. So what are those RT managers and directors and leaders, what are they to do when they need to provide these value-added services, but there's no justification, no CPT code behind them? How do they do that?
Yeah, so if I may preface before I respond, is that I would like to kind of just briefly at a high level kind of walk you through kind of the CPT code connection and how it ends up into the revenue side or productivity side for a respiratory care department. So you have the approved CPT codes for respiratory services. That CPT code, as I mentioned in the beginning, has a description. So we have to be very careful that we're choosing the right procedure to match that CPT code. The next item is there's always a charge code linked to that. And then linked to the charge code is a time standard, or also called an RVU. RVU is time standard for that. So if in a budget tends to capture the time standard, and that's where in most respiratory care departments or directors, that's what they usually see, is they'll see the volume they completed yesterday. They'll see the hours used for labor hours, and then they will see the next layer with that is based upon the labor hours used, the volume that was done, if that matches up to their budgeted that was approved for this current year. I want to go back a little bit to the hours part, because I mentioned about it. Part of the labor report will include actual like clock in hours used for staff. It could be eight staff members on a 12-hour shift. That equals X amount of hours. So when a budget is created, you look at two main factors: are your productive hours, and then your volume. And I don't want to get too much into the math behind that, but to answer your question, how do you account for the additional hours that you do not earn by a CPT code, charge code, which goes into a time standard? Is that I would suggest, this is what I personally do as a director, is I end up tracking my actually clinical hours that I cannot charge for. And I begin to, maybe over 3 months, maybe over 6 months, begin to add up these hours. And then you would then, if you're in the middle of a year where your budget's already created, now you have good data to explain what's called an hours variance on a labor report. Then for the next year's budget, you add those hours that are non-chargeable because there's no CPT code for them, and you add them to the productive hours for your new proposed budget. And then you divide that to your actual true volume, and you'll get a productivity factor. So now you can, for next year, you have your budget corrected because you added those hours in that are clinical interventions that you cannot charge for, that were not showing up before. Now we did a run rate and added them to now our new productive hours, and that will give you a new productivity number. So we can continue on with our clinical assignment given to therapists. They can then effectively meet the patient care needs, and then as a director level, the budget that comes out, or maybe yesterday's budget we look at, there should not be a labor variance. So that basically is, if you're in the middle of a current year, you would still track those hours. You can explain that to your respective A team that these are interventions that we have to do, but there's no charge code for them. But I will keep track of these, and then I'm going to add them next year's budget to my productive hours to build the right budget. So many times I'm a firm believer, don't let a billing rule change, or if you can't charge for something, change your clinical practice, because that ultimately, in my mind, affects patient outcome. I always like to build the correct budget for our current workflow or current demands for each department.
And I think what you just described, Joe, is important for all, and I'll say managers or directors. It's important for them to understand. And one of the issues is, if I only get credit, so to speak, for those procedures that CPT code, how do I document the others? And one way to do it is in the procedure, have a zero charge. So when you do it, the therapist checks it and you get X number of predetermined minutes for that. And then you take the procedure time from the CPT code of procedures, the procedure time from those without a CPT code, you add them up, and then that's whole. And I like the other thing you said about variance. As there is a variance, then the director or manager can explain that variance. Maybe it was a very busy cold and flu season, or maybe they had a change in hospital operations that changed that. And it makes it much more defendable for the manager who has both pieces of that. Now,
Correct.
what are you described the CPT system, and you described how you utilize the methodology for capturing the non-CPT coded procedural time. What are the advantages and disadvantages of a productivity system based upon CPT coding methodology?
I think I know the disadvantage is a lot of departments, as we have evolved into EMR systems now, and there's a lot of documentation areas, I believe there's a misunderstanding that everything they document makes it to the productivity system. So I always recommend to reach out to finance and obtain or request the approved CPT codes for respiratory care services, first of all. and that's also called the National CPT Code Charge Master. I also recommend every year, buy the CPT code book from CMS. That gives you up-to-date information on maybe new charge codes, some charge codes that have been deleted, or maybe some description changes within a current CPT code. Always be on top of that. So I think as a base level, know which CPT codes or charge codes that we can charge for, and make sure you have those activated locally within your department. Then, as I talked about previously, the other non-billable charge codes that we do a lot with our clinical intervention with patients that we have to account for hours for, that's how you would combine both. Now you have a clean look at your approved CPT codes. Now you're tracking your labor hours spent for clinical interventions that are non-billable. When you combine those together and then you build that correct budget, as I just mentioned previously, that's the appropriate approach, and to me, the appropriate budget to create.
Excellent. Just kind of summarize for our audience. You described the genesis of the CPT coding system that goes back in the 60s, was made mandatory in the 80s. And it was a system to make it standardized to link a procedure with time and then reimbursement, in this case for physicians. And kind of the second wave was an expansion of that to include some, but not all the services that we do. I think the third point is that RT leaders need to understand what percent of their total labor demand, services they provide that are value added that aren't captured by CPT codes, and they need to capture them. And as you said, it may actually be an advantage to have an EMR where you can do your clinical documentation, drop the charge, whether or not that's reimbursement or not, and then you capture the time. And the last thing, I think everyone buy the book every year. CMS, it's their system. It changes every single year. And just don't take chances. Buy the book every year, and then you'll stay current with that. So with that, thank you, Joe. Very, very helpful. Thank you very much.
Thank you.